Hello and welcome. We're going to get started in just a few minutes to give people time to join. Hello and welcome everyone. We're going to go ahead and get started. Welcome to this presentation on sustaining rural labor and delivery programs, strategies, and considerations. My name is Madeline Pick, and I'm the principal investigator of the Flex Monitoring Team. And we are excited to partner with Stroudwater on this work and share our resources with you today. You can go to the next slide. This work is funded by the Federal Office of Rural Health Policy within the Health Resources and Services Administration at the U.S. Department of Health and Human Services. We thank them for their support of this work. Stroudwater Associates has served the rural healthcare industry since its founding in 1985. As a healthcare consulting firm with experience in all 50 states, they advise a national healthcare market, including state offices of rural health, community-based organizations, major academic and tertiary care centers, rural and community hospitals, physician groups, ACOs, health plans, and provider organizations. Stroudwater's consulting team offers deep expertise and broad experience in strategic, financial, clinical, and operational areas. The Flex Monitoring Team is a consortium of researchers from the universities of Minnesota, North Carolina Chapel Hill, and Southern Maine, funded by the Federal Office of Rural Health Policy, to evaluate the impact of the Medicare Rural Hospital Flexibility Grant Program since the inception of the Flex program. The Flex Monitoring Team also operates and maintains the Critical Access Hospital Measurement and Performance Assessment System, also known as COMPASS, for easy access to financial quality and community measures. As a technical assistance provider to rural stakeholders, the Flex Monitoring Team provides access to a wide range of resources on relevant topics. Next slide, please. Next, I want to introduce our speakers. Eric Schell is a principal and board chair at Stroudwater Associates. With nearly 30 years of experience in healthcare financial management and consulting, Eric's areas of focus include assisting rural and community hospitals, rural health clinics, and physician group practices to improve financial and operational performance and develop strategic and operational plans. Dr. Kristen Ryder is a co-principal investigator with the Flex Monitoring Team. She has more than 10 years of experience conducting rural health services and policy research and has served as lead investigator on multiple projects funded by the Federal Office of Rural Health Policy on topics including the occupational mix adjustment to the Medicare Hospital Wage Index, swing beds, and the rural effects of health reform. And I am Madeline Pick. I'm the principal investigator of the Flex Monitoring Team based at the University of Minnesota. I have been with the Flex Monitoring Team since 2020, and my work focuses on quality of care and best practices in critical access hospitals. I have led several projects for the Flex Monitoring Team, including critical access hospitals' response to the COVID-19 pandemic, use of health information technology, obstetric services, and analysis of rural relevant quality measures. Now I will turn things over to Dr. Kristen Ryder.
Thank you, Maddie. It's nice to see everyone today. Welcome. As you all know by your being here, rural hospitals across the United States are struggling to maintain their labor and delivery programs, and many places have no access to labor and delivery care. Research from the University of Minnesota has shown that between 2010 and 2022, 238 rural hospitals have lost their obstetrics programs. And as you can see from the map, there are many, many areas in the United States which have no access to labor and delivery care. Next slide, please.
I was too busy looking at that slide.
However, work by Stroudwater has shown that sometimes closure decisions are based on analyses that include some inaccuracies in the way costs are accounted for or allocated to the labor and delivery program, or sometimes analyses that are incomplete that fail to consider some of the downstream and incidental implications of having a labor and delivery program. And so we came together and realized that there was a need for guidance to help strengthen the methods that are used by rural hospitals to actually evaluate the sustainability of labor and delivery programs. Next slide, please. And that led us to this webinar today. In 2025, the Federal Office of Rural Health Policy, Stroudwater Associates, and the Flex Monitoring Team came together to develop a resource for rural hospital leaders and state flex programs to help them develop stronger analyses in hopes that we could help bring these rural labor and delivery programs closer to sustainability and avoid some of the unnecessary closures of services in rural areas to preserve access to care. And that's what we'll be talking about for the majority of today. Next slide, please. This resource is really designed for critical access hospital CEOs, CFOs, cost report preparers, partners, and state flex programs in order to share with their hospitals. And it really provides a framework and somewhat of a checklist of things that hospitals can walk through to support fully informed decision making and help optimize resource allocation to help provide financial sustainability for rural labor and delivery and hopefully ensure continued access to care. Next slide, please. And now I'd like to hand it off to Eric Schell, who will walk through the resource. Thank you, Eric.
Thanks, Kristen. Good afternoon to most of you. Good morning to friends in Hawaii if you've joined. And yeah, I do want to add something to Kristen's comment in that she said it's really specific to critical access hospitals. I would ask just that a little bit and say rural acute care hospitals. There's lots of this report that are also very relevant to them. So I don't want to lose that. I mean, this is a resource. As you know, essentially as I was traveling around the country, as we were traveling around the country, there were some decisions to close labor and delivery units that made sense, and some decisions to close did not make sense relative to the way we think about financial performance. And so that this presentation, this report that was issued in September of 2025, all kind of highlight how we want you all to think in the rural critical access hospitals or the rural acute care hospitals when making decisions around obstetrics. Um, the first, and this is a real important concept, and differentiating between profitability from a fully allocated cost perspective and sustainability or contribution margin. And often, folks, when they're looking at the profitability of a certain department like labor and delivery, they look at the fully allocated costs and often through the lens of the Medicare cost report. And they say, hey, the revenue from this is $2 million. It's costing us $5 million. We've got to get out of this line of business from a fully allocated cost basis. The way we like to look at the financial evaluation of a unit like labor and delivery is through a contribution margin. And contribution margin is essentially it's revenue less variable expenses. And let's talk about how to think about contribution margin. And so and even if a entity like labor and delivery does lose money on a contribution margin, there are often downstream effects of the program that we can't necessarily measure through a financial pro forma. Geez, easy to say. And so let's talk about this. So our frame of reference always is that for rural hospitals to do better, there's an abundance, growth, and incremental contribution margin mindset. In other words, most rural hospitals do better when they take a big chunk of fixed costs and dilute it with incremental volume through growth, which creates thousands and thousands of additional contribution margins, mini contribution margins. And that is kind of our overriding philosophy. And it's how we work with so many rural hospitals and challenge the way they think versus many folks think that if we're going to do better financially, we've got to cut expenses. And that's just not a model that I've seen effective almost ever. And so what is contribution margin? You know, if it's going to be the basis for how we think about things, it's you know, I've got this graphic over here on the right. I'm going to point to it with the pointer. So if we look at this entire bar, this is the revenue that is generated from a service. Let's say it's a delivery, and let's say we generate $10,000 from the entire package of delivery services. There are very direct and variable expenses related to that $10,000 delivery. And we'll talk in the next slide about how to think about that. And then everything else is the contribution margin. The contribution margin. So in other words, this is all the cost, the fixed costs, and the other profit or loss is what makes up this amount right here. And so our philosophy has always been to figure out ways to dilute this big chunk of fixed costs here over incremental volume. As you can see, when we start talking about discontinuing a service like labor and delivery and the downstream effects of the revenue associated with that, that goes against kind of the way we think about rural hospital improvement. And so the next slide kind of talks specifically about variable costs. And here's an interesting, you know, kind of thought, and I think the accountants may think a little bit about this one, is that variable cost, which is absolutely critical to determining contribution, almost can't be determined by definition. And the reason is that there's a time frame associated with the decision made on to spend that incremental cost. So hear me out before you kind of roll your eyes. Revenue, right? So revenue is easy. Let's see, admission, $10,000. Variable cost. Do we think about it from a spot market? Do I admit somebody today? Decision making. Because if we're thinking about that, a variable cost is tiny. It is essentially, food, drugs, electricity. It's very, very small piece of total costs are truly variable, which means most are fixed. On a long range planning horizon, decision-making time period, your variable costs become much higher. Matter of fact, they come 100%. We close the hospital, right? From a long range planning perspective. On a medium range planning perspective, variable costs now begin to include all of the staffing costs of a specific unit, the additional costs associated with employee benefits, and if for obstetrics, if we have to have anesthesia, if we have to have surgery coverage, all that becomes part of the variable costs. And so we ultimately what we want to do is come up with this concept of variable cost, revenue less the variable cost of producing a sick care or healthcare function. If the decision making is today, that variable cost is very small. If it's medium term, like evaluating a contribution, there's many more costs included in variable costs, but not fully allocated costs. And if we're going to make it on a long term, a fine range, the variable costs are 100%. So now that we completely confused everybody, our accounting systems aren't going to give us this number because our accounting systems don't know what we're talking about or what our decision-making time frame is. Fixed costs, by definition, are costs that don't change, or step fixed change with fluctuations in volume. And then the contribution margin that we've been talking about is this revenue less the variable expenses, asterisk, depending on the time frame we want to make around decision making. There was an interesting study. I absolutely love this study. It came out last summer by the University of Iowa School of Public Health, where what they did is they looked at variable costs on that short-term planning horizon. Do we admit a patient or not? They called it the model estimated fixed and variable costs using the simple definition of variable costs is one that varies with volume. In other words, one more CT scan, one more ER visit. What did our costs change? And what they did is big regression analysis comparing thousands of cost reports over between 2011 and 2020. And if you come down here where the pointer is, what they determined is that the smallest hospitals, that simple process, the simple decision making, right, changes in volume, they found the smallest of rural hospitals, their fixed costs were about 93%, variable cost 7%. The medium small, fixed cost 90%, variable cost 10%. And then onwards to the largest hospitals had variable costs of 27%. But this really gets to that point of when we start thinking about volume or discontinuing volume. Every time we think about discontinuing volume, there's a negative impact on contribution margin because we have these 93% of fixed costs that no longer get diluted by that unit of service. So hopefully everybody's got that. But a great study, there's a reference to it if you need to pull it, but it's very helpful for understanding this. So what are the key elements? Again, the findings as over the last 10 years is traveling around the country is there are some labor and delivery departments that are closed because they appear to be losing money. And what I've found is just as many people are getting that equation right as they're getting it wrong. And what I don't want to do is have hospitals close their OB unit because of a miscalculation. And so there's three key areas here that we want to focus on and that were a focus in this report that came out last September. The first is getting the Medicare cost report right. Let's make sure that for cost report purposes, we've got costs properly allocated, we got statistically accurately reflected, and that we get our reimbursement right, number one. The second is making sure that when we sharpen the pencil around this contribution margin equation, we're looking at labor and delivery from that medium-term perspective. And how exactly do we want to do that? And then the third is okay, if the program is losing money now, and we've got the cost report right, and the contribution margin calculation was correctly applied, are there ways to improve the efficiency of the labor and delivery department? And so those are the three areas that we want to touch on during this presentation, and that were part of this report that was issued last September. So the first is getting the Medicare cost report right, and understanding that kind of within the cost report worksheets. The worksheet A is where we allocate our expenses into the cost report template. The worksheet B, where we allocate overhead expenses to each of the departments within our cost report, and making sure that the statistics that we are using to allocate the overhead costs and making sure that they are all reasonable. And so kind of this workbook that was issued actually explains some of that. The most important concept we can all understand is that there's a labor and delivery ancillary department, and it shows up as an ancillary department below surgery, below anesthesia, and it's a row on the worksheet A where it accumulates the labor and delivery costs, department costs. the appropriate treatment and determination of labor and delivery ancillary department costs is we take the costs of that department, the nurses and the supplies and kind of the benefits and all of these costs, and we multiply it by the percent of time the mom is in active labor versus the total amount of stay. Again, this is for labor delivery recovery postpartum rooms. Okay, so most rural hospitals have these LDRPs. And so let's say we accumulate $2 million of costs of nursing to care for our moms as they deliver their baby. That whole department, let's just say on a direct cost basis, is $2 million. Appropriate allocations would say, okay, the mom is in the labor and delivery department 10 hours versus a 50-hour stay. 20% of that 2 million should stay in the labor and delivery department. The remainder of those costs go up into med surg. And that is the most important fundamental that we can get right here. And the reason why that's so important, especially in the critical access hospitals, is your med surg is in 99 out of 100% cases, it's your highest cost-based reimbursed department from a Medicare perspective. And so to the extent we can take 80% of that $2 million cost and take it out of labor and delivery, which in most cases, if Medicaid is not paying on a cost basis, is zero cost-based reimbursed, we're taking 1.6 million of costs and moving them up into med surg that is often 60, 70, 80% cost-based reimbursed. And so that's a really important piece of this. And so that's the salary and non-salary, the medical surgical costs. The next is the statistics. Often what I see is a LDRP with 4 beds that has 3,200 square feet associated with it. And what the statistic is doing is it's taking depreciation, it's taking housekeeping, plant operations, and it's all allocating those costs down to the ancillary department, labor and delivery, which is often very low cost ancillary, cost-based ancillary department. And so, square foot is a big driver, 3,200 square feet. If you actually took the total square feet of these 4 LDRPs and the office around them and multiplied it by that 80 or that 20%, which is the time the mom's in active labor, 80% of that square feet actually belongs up in med surg, which is your highest cost-based paying department. So we have to make sure that when we're doing these calculations, that we're accurately reflecting not only the direct dollar cost of that department, but also any statistic that gets allocated to the ancillary department, labor and delivery. So this was a case study I ran into. There was a hospital out west that had a pretty large. They had done over 300 deliveries in the prior year. And what happened is they were allocating about $3 million in direct labor costs and labor and direct costs of the ancillary department, labor and delivery, to this department. And then through the step down process, the cost report allocated another over $3 million of cost to this ancillary department. And this hospital, critical access hospital, happened to be in a state in which Medicaid paid zero cost-based reimbursement. So all $6 million of this cost was allocated to a zero cost-based reimbursement. The hospital made the decision to close their OB program primarily because of the perceived loss of about $3 million. In addition, they were having some challenges, staffing with providers. But they made the decision to discontinue their labor and delivery program, and it was a very valued service with over 300 deliveries. When we dug into the cost report implications, what we found was that just as we had talked about, there was no allocation of costs or that labor and delivery percent, the mom's time in active labor, that 20%, 80% of this $6 million of cost should have been allocated up to the med surg unit, which for this hospital was its highest cost-based payer mix. Once they figured this out, all of a sudden they realized they weren't losing $3 million. They were probably breaking even on this program. And they chose to reinvest. They were able to recruit new providers, and they were able to open their program up about 6 months after this. And so, let's just make sure all of us, for any of you participating, if you're a critical access hospital, work with your cost report preparers to make sure that we've got this allocation between labor and delivery and med surg. The other point I want to just a comment on, if you think about the mom's stay, once she gets outside of the active labor, her statistic becomes a day, right? So she's in now 2 days. That 2 days is part of the denominator in your Medicare cost per day calculation, right? So you take all your routine costs, $5 million, you divide it by patient days to come up with the routine cost per day, which is then multiplied by your Medicare days to come up with your Medicare routine costs. If you aren't allocating any of the labor and delivery costs, the ancillary department, up into med surg, but you're using that mom's 2 days as a denominator, you've artificially deflated your Medicare payment. So it's really important we get this cost report right. If we had time for comments and questions, we'd do that right now, but we'll wait till the end and you guys can fill up the question box. The next important part is making sure, we had talked about contribution margin, right? And now we're going to talk about that medium time frame for decision making. But there's also a short-term spot market time frame for decision making, and I'm going to talk about that in a second. So what we have to think about is, what would the cost structure of this hospital be and revenue structure be if OB were no longer to be part of the hospital? And so we have to kind of close our eyes and say, okay, what costs would go away and what revenue would go away? First of all, when we lose, and this is an interesting opportunity for all critical access hospitals automatically qualify for 340B, but rural acute care hospitals have to have a certain Medicare disproportionate share percentage, and discontinuing the obstetrics program is likely to bring down your Medicaid payer mix to the point where you either may or may not qualify for 340B. Even if you qualify for 340B, your disproportionate share percentage is likely to be lower than it would be without the program. So there's this kind of, let's make sure we got the revenue right on this. And then there's also these incidental services. We looked at several years ago, we did a OB service line profitability assessment, contribution margin for low volume. They're only about 100 deliveries. And what we found is that on the direct delivery, the delivery department, we had lost money, but the incremental contribution margin of the ultrasounds, the lab work, the clinical visits, and all that, the incremental contribution margin for these services essentially made up enough money to break the losses in the delivery department down. And this was a state that did not pay Medicaid on a cost basis as well. And when we start thinking about these, kind of ultrasounds, now we have to think of the spot market decision. We're going to staff our ultrasound department whether we have OB or not. We're going to have lab work whether we have it or not. And so what we have to think about now is, if we didn't have OB, those additional 100 ultrasound tests would go away. And the contribution margin then, which is the revenue less the incremental expenses, which for ultrasounds is not a whole lot. That revenue, that contribution margin for all of those services that would go away would be eliminated. And now we have to compare and include in our study the loss of contribution margin on these downstream ancillary services, the loss in that versus what we would gain by discontinuing the direct service of the labor and delivery program. And so this is we got to be pretty careful about that one. Yeah, so this is really kind of highlighting what I just talked about there, where an accurate contribution margin analysis considers revenue and cost that would be different if the labor and delivery program was closed versus maintained. In other words, close your eyes and think of your revenue center and cost center, revenue of your revenue and your costs with OB and then without OB. And then the other part here is making sure that we've got, I'll get to this in the case study, but making sure that when we're looking at the costs of the ancillary services, for example, when we're looking at ultrasound, I've had people come up with the contribution margin of ultrasound tests using the ratio of cost to charge from the cost report. So what they do is they multiply the gross revenue of ultrasound for these incremental services by the ratio of cost to charge from the cost report to come up with an imputed cost of that, right? Because we're trying to come up with contribution margin, which includes this variable cost. The problem with using the ratio of cost to charge from the cost report to assess variable costs is there's a whole bunch of fixed costs built into that. So we have to be super careful when we start imputing costs of ancillary services like lab or ultrasounds. It's almost easier just to close your eyes and take a guess, because that's going to give you a better number than if you try to use anything driven out of the cost report. So the case study that I have to highlight this is that a couple of years ago was working with this was a rural acute care hospital that had a decent obstetrics volume. I think they were doing about 150 deliveries, 150, 175 deliveries. They had a new physician, very popular family physician that was delivering a majority of the deliveries in this acute care hospital. But this hospital was losing money, and so they had their cost report preparers run an analysis to say, hey, what should we do about this obstetrics program? And the cost report preparers came back and said, look, this thing's a dog. It's losing nearly $800,000, and you really need to get rid of it. And a couple things is, again, acute care hospital, the deliveries and the Medicaid payer mix on the deliveries was enough that took the disproportionate share percentage to a level that enabled 340B within this rural acute care hospital. The 340B, just the contracted retail pharmacy piece of it, was worth about $2.5 million a year to this acute care hospital. In other words, if they would have discontinued OB, they would have lost their percent eligibility to meet 340B requirement, and they would have lost $2.5 million. The other piece is when they were evaluating the downstream, the ancillary revenue on the ultrasounds, the lab tests. This is the example where they actually, to determine the cost for these services, they took the ratio cost to charge from the cost report for each of those ancillary departments and multiplied it by the charges. So when they were trying to determine variable costs for this downstream revenue that would go away if these services were to go away, they were inflating the cost, understating the contribution margin. So it was great because the CEO of the hospital, he sent me this stuff. He said, "What do you guys think? We got to do something different." And I said, "Well, if you closed OB, this is going to cost you well over $1.7 million, and you really need to take a different approach to improving your financial performance in your hospital." The last area, we might give you guys back a bunch of your day here, is opportunities to optimize efficiency or reduce costs. Again, if you've done your contribution margin, your service line assessment, and you checked all your boxes here and you got it right, and it's still losing money, are there things that you can be doing to optimize the performance of the clinic? And so strategy 3 within this report, this September report, kind of highlights that. Some of the big ones are just are there opportunities for providers and staff that increase their efficiency? Are there opportunities through either rural health clinics or federally qualified health centers that can help us improve our efficiency? And so, I was working a couple of years ago. I was working with a rural hospital in up in the Northeast, and they had a labor and delivery program, fairly limited, probably 150, 175 deliveries a year. And because they were using OBGYNs to staff their department, they were paying $1 million a year for pediatric call coverage. And that gets pretty darn expensive for a rural hospital with 175 deliveries. And so, one of the opportunities is family physicians, FPOBGYNs that there's a couple benefits of having them. The first is that we don't have to cover pediatrics call. And then often the family physicians, when they're not delivering deliveries, they can be seeing patients in the family practice mode versus the GYN and OB mode. And so it's almost an ability to increase efficiency of provider costs through kind of diversifying their revenue stream into just family practice care and then the OB care. So that utilization of family practice physicians, great opportunity. In one of the highlights that you're going to see later in this was back a year and a half ago, we had a group of innovation centers around OB present on things they were doing to have successful obstetrics programs within their rural and critical access hospitals. Most of them had either full or partial family practice OBGYNs to cover the service. Low volume programs. Often it's about keeping the skills of the providers and nurses at the high levels required within these units. And so one of the potlucks, one of the innovation centers that came and presented a year and a half ago, we're talking about how they would round in a larger medical center that the rural hospital is affiliated just to keep their skills up. So, great opportunity there. What about FQHCs and rural health clinics? Rural health clinics, obviously, if to the extent we can roll the family practice provider, the family practice OB provider into the rural health clinic, whether it's grandfathered or at this point, the cost is the UPL is getting high enough where a lot of the cost can be reimbursed through the rate, but kind of getting some of their cost reimbursed through enhanced rural health clinic reimbursement, both Medicare and on the Medicaid side, great opportunity. Partnerships with federally qualified health centers. One of the innovation centers that presented a year and a half ago in Texas talked about the fact that several years ago, what they ended up doing is spinning off their 3 OBGYNs into a local community health center, subsidizing the community health center at a significantly reduced cost to what they were originally using. They were losing about $650,000 on their OB program before they spun off the providers into an FQHC. The FQHC was able to leverage 330 funds and also had some tort reform savings. And so the subsidy that the hospital was now paying to have the obstetric OBGYNs in the FQHC was cut by 2/3 to 3/4. And it was a great win for the entire community because that service was able to be maintained by this partnership between the critical access hospital and the community health center. Um, yeah, this was kind of a sad story. This shows the negative effect of not having that opportunity. So this was a critical access hospital in the Mid South area, and they only had one FPOB. Now she was included in the rural health clinic, but by only having one, what the hospital had to do is, whenever this doctor needed a break, not being on call 24 hours a day, 7 days a week, they had to bring in locums and locum OBGYNs. And so all of that professional time was no longer part of the family health center reimbursement. It was paid off, not on the cost, a non-reimbursable cost center. In addition, this hospital did not have an inpatient surgery program. And so any of the costs of the surgical team, the on-call costs of the surgical team, and were all incremental costs that had to be added on to this program as a true variable cost. And that's another thing I do want to say. Often when looking at contribution margin, uh, the surgical team, right? We got to maintain surgery and anesthesia 24/7 when we're having an OB program. When we start looking at variable costs of OB, if we are already doing surgery on a 24/7 basis, then that incremental cost of staffing the OR at night doesn't have to go completely into the OB program. However, if the only reason that we're maintaining surgery, anesthesia, and the tech team is to support OB, then unfortunately that becomes a variable cost of obstetrics. This case for this hospital here, by the time we factored in the on-call cost of having the surgery team, because they did not do 24/7 general surgery or orthopedic surgery or any other surgery, and when they had to pay the locums for OB services, when this one single provider had to go away on weekends or something, those incremental costs were, most of them were non-cost based, and our contribution margin showed the program lost this hospital about $800,000 a year. This hospital was fairly cash strapped, and they made the decision to close the OB program. Good news is the OB took up a position in a community hospital about 25 miles down the road, and most of those services now go to this one hospital where this provider relocated to. So here's one, that once you do all the numbers, the contribution margin was done correctly. But when we don't have the opportunity to leverage our family practice doctors, we don't have the ability to leverage our rural health clinic in this one case for the locums. We lost the efficiency that would have helped us maintain this program. Um, you know, it's really important to note that if a hospital adheres to all the recommendations in this document, it still may end up not being a viable program. And so what we've got to do is there an opportunity to partner with our community around additional resources? If OB is a really important part of the identity of this hospital and the community views it that way, is there an opportunity through philanthropy or tax dollars, if it's a county-owned hospital, to support this obstetrics program on behalf of the community? And so what I want to do is turn it back to Maddie to kind of talk through how we want to move forward from here.
Sure. Thanks, Eric. Thank you, Eric and Kristen, for a wonderful presentation. We'll be moving to some Q&A here shortly. So as I go through a couple of additional resources, feel free to drop your questions in the Q&A box, and we will try to get to those here in a few minutes. So to access the resource that Eric has been talking about, you can scan this QR code or use the link in the slide. Again, attendees of this webinar will receive an email with a link to the resource following this presentation as well. Next slide, please. And before we go to the Q&A, I wanted to bring attention to three other resources on this topic that are available on the Flex Monitoring Team website. You can go to the next slide. So the first resource is on the availability of obstetric simulation training by state. So obstetric simulation training is an effective method for clinical health professionals to maintain skills, which is of particular importance for rural hospitals with low birth volumes and for rural hospitals that do not have obstetric units but need to remain prepared for obstetric emergencies. This environmental scan lists trainings by state and can be used to identify available trainings in your state or neighboring states, foster new partnerships with organizations offering simulation training, or use as examples of rural specific training programs. And again, you can access that with the QR code or the link on the slide. Yeah, next slide.
Sorry, Maddie.
No worries. Our second resource is a case series on maternity care innovation in critical access hospitals. This case series describes interviews with 6 high-performing CAHs, including the benefits of their perinatal quality collaboratives, use of safety bundles, ongoing obstetric training for staff, and other strengths of their maternity care services.
And that was what I referenced a little bit in some of the innovation sites. And this study kind of highlights each of these 6 sites and some of the specifics that they were doing to maintain strong and vibrant OB programs.
Yeah, thank you, Eric. And then our third resource is a brief on reporting and performance of maternity-related quality measures in CAHs. So in this brief, we describe characteristics of CAHs with and without labor and delivery services, and then describe reporting and performance on key quality measures related to maternity care and birth outcomes. Again, the Sustaining Rural Labor and Delivery Programs resource that Eric and Kristen presented on, along with those additional resources, can all be found on the Flex Monitoring Team's website, and you can access all the links and QR codes in the slides following this presentation. So now I will turn things over to Dahlia to help facilitate the Q&A.
Everybody. Thank you to our presenters. We are now going to move into the Q&A portion of this webinar. So I did put this out to the chat, but if you have a question for the presenters that you have not already put in the Q&A function, we have a little button down in the menu bar below. Please feel free to type something in and send it. We're going to try and cover a few key questions during our remaining time today. We may not address all of the questions, but for the key ones, we will cover during this piece, and then whatever we do not cover, we will try and follow up offline. So thank you for those of you who have already sent questions in. And I will start by sharing the first one that is at the top of my screen, which is, are cost report misallocations really that common in practice? How often does this actually come up?
Good stuff. So I'm finding it probably in 30 to 40% of hospitals that I see, whether it's the allocation of the direct costs or the statistics. So some may have the direct cost of the salaries correctly allocated, but then the statistics, like I had mentioned that example of the 3,200 square foot LDRP, when if you took, that was the entire space versus if they would only taken 20% of that, it would have been a much lower number. So I'm seeing it 30, 40% of the time that I'm seeing cost reports, but maybe I see a lot of hospitals that are struggling financially, and this may be one of the reasons.
Thank you, Eric. The next question is, how relevant is the cost report section of this report for the OPPS hospitals on this call?
It's not as relevant other than to determine your costs when you're starting to look at your contribution margin and you know kind of piece together. It's a good place to start with costs and then make sure that you're thinking about fixed, you know, kind of breaking out the fixed portion of costs when it's coming up with contribution margin. It's not relevant at all for the reimbursement other than your disproportionate share percent of your Medicaid days. And then if your state has any state payments, I know, like, for example, Texas has programs that definitely increase your Medicaid volume impacts your costs, and sometimes there's some reimbursement there. So source of information for acute care hospitals, and definitely an opportunity to manage your disproportionate share percent.
Perfect. We have a sort of a question about thoughts on this from the audience. There are quite a number of hidden costs tied to OB, like OR call, nurse call, CRNA call, and liability insurance increases. CAHs don't necessarily have many emergency surgeries, so many that choose to evaluate the OB program include these hidden costs because they closed OB. They would also stop emergency surgeries. What are your thoughts on this approach?
Yeah, so again, if you are going to be doing 24/7 access to surgery, whether you have OB or not, then those incremental costs of that standby capacity should not be dumped squarely on OB. Shouldn't be dumped on it at all if you are going to provide these services with or without OB. If the only reason why you're providing 24/7 surgery is because of your OB program, then it is my belief that you have to attach those costs, right? Those variable costs related to those standby capacity to the OB program when doing a contribution margin assessment. Did I answer all of that? Was a big long question.
It was a big long question. I think you did. Unless anyone else wants to chime in on that piece. But we also have a question about how does an outpatient cost factor in? For example, those patients who are triaged not as in labor and delivery and thus discharged undelivered, or those that cause completing routine prenatal testing on, but then still impact the overhead costs.
Yeah, I'm not sure I'm understanding the question. So we don't do the deliveries in our hospital, but we're doing all the prenatal stuff, the ultrasounds and the lab tests and the clinic visits. We're keeping those in our critical access hospital. Again, I look at that as incremental volume that creates contribution margin because we already have all those costs. That comes back to that 10% variable costs, the 90% fixed costs that the study talked about. And so I think that I actually, if we can't do the deliveries, then we should partner with a hospital in our region that could do the deliveries as long as we can do all the prenatal and post follow-up so that the mom is still part of our community and our health system. I don't even know if that was close. Next.
Have you seen cases where general surgeons are utilized as C-section providers to help with the call burden for OB providers?
Yeah, that was what was happening with that hospital I was mentioning in the one in the mid South that ended up closing the program because general surgery had to be on call, and it was the general surgeon backing up the FPOB, and so it was difficult. It was difficult. So yes, general surgery is often backing up the OB programs.
Is there an absolute number of deliveries that have to be performed per year to meet a minimum contribution value to sustain full spectrum maternity care?
Yeah, that's an interesting question. So there's a lot of variables that play into that. Some of those efficiency questions, can we run the provider through our federally qualified health center or, our related federally called our rural health provider-based rural health clinic? Can we dilute some of those costs through other services? What's the reimbursement model look like? I mean, are you in a state in which, Alaska, 100% of charges, Blue Cross pays in Alaska, versus Alabama, where Blue Cross pays, 22% of charges. So there's a lot of different pieces that fall into this minimum count. I had mentioned the one hospital in the West that we had a different one in the West, very low volume, only about 100 deliveries. And we found that the program broke even And it primarily broke even on the backs of the downstream ancillaries that when we said, okay, if this program goes away, these OB providers will no longer be in this community, and we were going to take away from this hospital the contribution margin associated with the clinic visits, the lab volume, the ultrasound, and whatever downstream, the GYN surgeries, all of that goes away. And so even at 100, but this is a state which had decent commercial reimbursement. It was in Colorado, and so I that's a very interesting question, and it's one of those, it depends.
All right. We also have a question. If we are working with a facility considering closing labor and delivery services due to cost, does your group review financial records to ensure there isn't a miscalculation? And what other resources exist for situations like these?
Like financial records, as in, I mean, that's frankly what I did for that one hospital in the Southeast, that acute care hospital. They sent me their analysis, and I just took a flip through it, and I said, you need to ask this question, and this question, because this doesn't seem right. So, I mean, this isn't, I don't want this to be an advertisement for Strawwater at all. This is really about education. And so what I'd love to all of you to do, be able to take what we had talked about today and think through. And if something just doesn't look right with the study that you're doing, the service line analysis, you always just send me an email or whatever. And we can get you an answer.
All right. I'm assuming we're getting a huge influx of questions all of a sudden. So thank you for interest. I'm gonna probably cover one or two more, and then I think we're gonna transition away from Q&A. But if we did not get to your question, we will certainly follow up after. I have one in front of me, the next one in order. For a small call with OB, most of the cost is LDR nursing salaries. We staff 2 RNs per shift, and it seems that there are times when the unit is slow and we could safely staff with 1 RN. There are also times when we need to staff up when the unit is busy, nurses making time and a half. Has anyone successfully covered the compensation costs of RNs by placing them on salary, not hourly employees, coming in only when needed and staying home on days when not needed? So alternative nurse staffing models for small LDRP units. Is there any thoughts on that?
Well, again, just by the way we had talked about that allocation, a lot of those nursing costs are going to move up into your med surg unit. If it's very low percent, then excuse me, if the labor and delivery active labor and delivery time, like that 10 hours of the total stay, and it's 20% of the total stay, first of all, we're gonna take 80% of those costs and move them up into the med surg unit to be cost based on Medicare is going to step in and pay their fair share, and Medicaid, if it's a cost-based Medicaid state. That's number one. And then if you want to get more of that reimbursed, develop a big swing bed program and get that percent from 80% to 90%, and most of those costs are going to get reimbursed. So that's just getting the reimbursement right. From a staffing perspective, man, is there any opportunity? And this is a tough one. Nurses, an OB nurse wants to be an OB nurse, but cross training between med surg and OB. Again, optimize the utilization of your nurses through cross training. I'm not a nurse. You can see my credentials, CPA, MBA. Having a conversation like this will probably get me beat up by some nurses, but that's an opportunity. Are there ways to improve the efficiency? Maybe you have an idea there. Maybe pay on a flat basis and then only come in, but it's still going to show up on a cost. You're still going to have to cut the check, and it's not going to be any less than otherwise. So let's get the reimbursement right, and let's figure out if we can improve efficiency through cross-pollination with other nursing departments.
Perfect. All right, we're going to have this last question and then we'll move on. How much is too much dependency on locum costs for OBGYN services?
That's again, that's a really tough one because usually when the locum OBs come to our hospitals, we're not going to be able to, kind of improve their efficiency by including them in the rural health clinic, seeing family practice type visits. They're going to be outside. They're going to be fully professional fees, non-reimbursed on the cost report. So it becomes very, very expensive for a critical access hospital. And I guess the question becomes when you're doing that contribution margin of your service line and you include the entire, $500,000 cost of that locum as a professional fee, non-cost based, that's a tough one to overcome. But just make sure you cross the T's, dot the I's on the other things that I had talked about, making sure that you're thinking about variable costs right. Making sure that we're thinking about improving efficiency through leveraging RHC or community health center. All of these are opportunities for us.
All right, thank you so much. That is going to conclude our Q&A portion. If you wouldn't mind moving on to the next slide. I think we're going to wrap up here. So thank you to everyone who has joined us for this presentation today. All registrants are going to receive a follow-up email with the slide deck and the link to the resource that was developed by this team. We will also give the opportunity if you have any additional questions that you would like to ask, feel free to follow up to that email, and we will make sure that you get connected with the right people moving forward. So thank you all for
Let me
joining.
just say, just real quick. If you do get a question out, I'm traveling for the next 2 weeks, so I will return it. It just might take 10 or 12 days before I can return. Maddie, do you want to close out being the leader of this? No.
Sure, yes. Thank you everyone so much for joining us today. And again, you'll receive all the information via email, and hope everyone has a great rest of their day.
Good deal. Thanks all.